uh, Radiant Flashpoint webinar series, and it's going to be a 45-minute session and followed by 15-minute Q&A. And people in the audience, you may submit questions via the chat box throughout the session, and we will address the questions in the order they are received. And please feel free to ask questions at the end as well. And it is now my pleasure to introduce Dr. Venkat Ramesh, who is a consultant in infectious diseases at Apollo Hospital in Hyderabad, India. He completed his MRCP in 2017 and earned his diploma in tropical medicine hygiene from UK in 2021. Dr. Ramesh is actively involved in research and has several publications under his belt. It is now my pleasure and honor. I'll turn the attention towards Dr. Ramesh. Dr. Ramesh.
Thank you. Thank you very much for that kind introduction. Special thanks to Dr. Jyotsna for giving me this opportunity. So I'm guessing you can see my screen now, right?
Yes, we can. Thank you.
Okay, thank you. So I shall now go ahead. So I aim to complete the talk in about 40 to 45 minutes. I will skip past some slides that may not be applicable to nuclear medicine physicians, but yeah, I will focus the core of my talk in how we utilize nuclear medicine in modern infectious disease practice. So there are a lot of personal biases involved, and this is more of our experience. So I was just looking at what really is the difference between nuclear medicine, molecular imaging, and trying to really understand what is done. So the Society of Nuclear Medicine and Molecular Imaging defines the nuclear medicine or nuclear imaging as the use of very small amounts of radioactive materials to evaluate molecular, metabolic, physiological, and pathological conditions of the body for the purpose of diagnosis, therapy, and research. Whereas molecular imaging is defined as the visualization, characterization, and measurement of biological processes at the molecular and cellular levels in humans and other living systems. So really complementary to each other. So this is where we practice, Apollo Hospitals in Hyderabad. And as an infectious disease physician, we have a department here consisting of 4 attendings. And there are, in our hospital, there are many pulmonologists and internists who also practice. And there are many branches of our hospital across the city. However, it's only in our branch where we have access to nuclear medicine, especially PETCT. And in terms of how our healthcare system is, scheduling an appointment is very easy. Like there was a patient who underwent a whole body PET-CT today morning, and I had put the order in last evening. So I requested Dr. Jyotsna to for the test, and it was done. It is covered by insurance. And as infectious disease physicians, we see a lot of patients with tuberculosis and advanced HIV. We're also a transplant center with multiple solid organ transplants and hematopoietic stem cell transplants. So there is a huge host of immunosuppressive patients. As infectious disease physicians, what most of our consults are for fevers of unknown origin. And most of what we order is whole body PET-CT with FDG. One barrier to nuclear medicine, to whole body PET-CT in the city is the high cost. So depending on the center, it can vary from the equivalent of 150 to 350 US dollars. So now, just before I go into what we do, I'll just point you to some papers that have been published about using nuclear medicine in diagnosing infectious diseases. This was published by in Open Forum Infectious Diseases, and I will cover some of what has been described in this paper, but the key word probably here is imaging wisely. And I think that is a very key part of how we order tests. Also, there was this paper published in Journal of Nuclear Medicine talking about nuclear imaging of bacterial infections with state-of-the-art in future directions. And just before I actually go on to the core of my talk, I'll just say that the what I will be discussing are essentially case-based scenarios and some of our cases that where we have utilized nuclear imaging and how it really has helped us in reaching a particular diagnosis and ultimately beneficial to the patient. So the first case rather is a case of ring enhancing lesions in the brain lesions in an immunosuppressed host. So this was a 24-year-old female who had presented with holocranial headache for 7 weeks, dull aching type of headache, and in the week prior to admission, she had worsened with fevers and multiple episodes of vomiting. So she was evaluated prior to the current admission for 4 months prior for fever and constitutional symptoms of 1 month duration. Cervical and retroperitoneal lymph nodes, multiple liver nodules were found at the time of evaluation, and serum ACE levels were elevated. And basically, what she had was on biopsy of those lymph nodes, cervical lymph node, epithelioid granulomas with multinucleated giant cells without evidence of caseous necrosis, testing for TB, including PCRs, testing for fungi were also negative. So given the elevated ACE levels, the epithelioid granulomas on lymph node biopsy, she was presumed to have sarcoidosis and started on immunosuppressive treatment. So I'll just skip these slides. This is describing what it is. So she was on steroids, methotrexate, and azathioprine, and she had an uncomplicated delivery through lower segment cesarean section 1.5 months prior to the onset of her symptoms, and after that she was placed on the other immunosuppressive therapy. So when she came in, she was basically quite sick with a poor Glasgow Coma Scale score. Pupils were sluggishly reactive, and there was some evidence of papilledema. And I'll just go straight away to the MRI imaging. Testing for HIV was negative. Tuberculin skin test was positive. And you can see these multiple ring enhancing lesions on MRI in the cerebral cortex, basal ganglia, and left cerebellum. And this is also seen in this. So in such a case, what we had done was, because there was a very high risk of lumbar puncture, we'd also got a PET-CT done, and I will show you those findings. So the CT showed ring enhancing centrally necrotic nodules in the left frontal lobe and caudate nucleus with perilesional edema, miliary nodules in both lungs. Liver was studied with numerous hypodense nodules, and multiple enlarged upper retroperitoneal and mesenteric nodes were noted. The largest precaval node measured 2.6 into 1.5. And the abdominal nodal uptake was noted with a SUV max of 11.2. The others did not show any uptake. She was on immunosuppressive treatment. So this can be seen here. And here again, one sees upper retroperitoneal and mesenteric nodes with the largest precaval node showing a lot of uptake. And these are the miliary nodules in the lungs. So at this time, the differential diagnosis was tuberculomas with tuberculous meningitis, because she was on immunosuppressive treatment. Toxoplasma, encephalitis, cryptococcus, CNS nocardiosis, bacterial abscesses, neurosarcoid, neurocysticercosis. Again, this would come low down. But in India, as you will see in this talk, a lot of our diagnoses revolve around TB, because India is the world capital of tuberculosis, and every presentation of tuberculosis we do see more or less. So in fact, it's so common that we've seen like extremely rare presentations, and it's always at the back of our heads. So lumbar puncture revealed an opening pressure of 31. CSF analysis was done, which showed 48 cells with 90% lymphocytes, 10% neutrophils. CSF protein was high, 89. And so importantly here, PCR was negative for Mycobacterium tuberculosis on the CSF, right? It was also negative for HSV. So we went ahead and did a CT-guided fine needle biopsy of the abdominal lymph node. And this was positive for tuberculosis with rifampin being sensitive. And then she was started on anti-tuberculous therapy and steroids. After 8 weeks of incubation, cultures had shown, again, growth of Mycobacterium tuberculosis. And it was a drug-susceptible TB. So this is just how it looks. And growth on midget showing the tubercle bacilli. So this is just a microscopy of that showing acid-fast bacilli. So she was started on ripe treatment and steroids, and then she improved, and she's doing well. So what I would like to emphasize here is that the diagnosis was really clinched on biopsy of a lymph node because the CSF was suggestive of tuberculous meningitis, but not diagnostic, because the sensitivity of TB PCR in the CSF is at best about 50%. So a negative TB PCR in the CSF does not in any way exclude the diagnosis of tuberculosis. And the fact that she had tuberculosis outside the CNS was indirect proof of tuberculous meningitis. So really won't go into too much of depth because I try and cover as much as I can. So definite diagnosis can only be made on brain biopsy or a CSF that is positive, but evidence of tuberculosis elsewhere increases the likelihood of CNS TB in patients with compatible clinical features. So the final diagnosis in this case was disseminated tuberculosis. And we did a study on diagnostic utility of whole body PET-CT in patients with suspected CNS tuberculosis. And I presented this as a poster in the annual Infectious Disease Society of America meeting. So basically what we did is we looked at patients who had probable or possible tuberculous meningitis, and who, so essentially possible or probable is based on the likelihood in terms of clinical symptoms of more than 7 days, lymphocytic pleocytosis in the CSF with low glucose, high protein, evidence on other surrogate evidence on imaging such as hydrocephalus, basal exudates, infarcts, tuberculomas, but that would still not make it definite. So probable or possible is what it would be defined as. So these were patients who underwent whole body PET-CT with 18 fluorodeoxyglucose and intravenous contrast, and had been on less than 1 week of anti-tuberculous therapy at the time of PET-CT, and there was a response to ATT on follow-up. So often with tuberculous meningitis, because it is a medical emergency, we do not wait for diagnostic certainty in treatment. We do initiate empirical anti-tuberculous therapy and steroids, and then proceed with further evaluation. So we studied actually only 12 patients. Now we have a few more, but this hasn't been updated. So we had 50% of patients had definite evidence of tuberculosis outside the CNS. 25% had, that is definite evidence in the sense PCR being positive, like this patient that I presented. 25% had no evidence, and that is about 3 patients. And there were some patients where even on for example, lymph node biopsy or a lung biopsy, there was only histopathological evidence of tuberculosis, but not definitive evidence, because the sensitivity of TB PCR is not 100%. And we often say that tuberculosis is a disease that there is no test that will help you completely exclude tuberculosis. And the best way to exclude tuberculosis is definitive alternate diagnosis. So most of these patients actually had cervical lymph node involvement, pleural involvement, some of them had parenchymal pulmonary involvement, mediastinal nodes, etc. So this is another case that we recently had seen where there was an elderly male who had undergone a liver transplant a couple of years back. He had presented with fever, headache, increasing drowsiness for about 8 to 9 weeks. So something like a chronic meningitis syndrome. The MRI which was done was suggestive of meningitis and ventriculitis with hydrocephalus. Again, this patient had high protein, low sugar, lymphocytic pleocytosis with negative TB PCRs on 2 occasions. He was on empirical ATT and steroids with limited improvement. So this is another patient, for example, where we would be quite keen on getting whole body imaging done to look at other sites for tuberculosis. And in this gentleman, actually, there was only brain involvement, as you can see in the left temporoparietal lobe. There's increased uptake. So PET-CT did not reveal any evidence of disease outside the CNS. So the plan was actually for a meningeal biopsy. But on the third CSF sample, the cryptococcal antigen and cryptococcal PCR was positive, which very surprisingly was negative in the initial 2 samples. And this patient is presently under our care. He's on liposomal amphotericin B and fluconazole. So this is a diagnosis of cryptococcal meningoencephalitis with hydrocephalus. This is another gentleman we had managed along with the pulmonology service. He was an elderly male with prior pulmonary tuberculosis and had presented with chronic cough, dyspnea, and weight loss. And you see this kind of dense consolidation in the right lower zone, and with some cavitation too. So he underwent a bronchoscopy which showed gram-positive filamentous structure suggestive of nocardia, as well as pulmonary aspergillosis. So he had 2 entities. We had put him on Bactrim for nocardia and voriconazole for aspergillosis. And in this setting, PET-CT was used more for prognostic purposes or in terms of monitoring disease response to therapy. And this you can see, these are the images taken about 3 or 4 months apart. You can see this is the one on the right is where there is the latter image. This is at the beginning of therapy, more or less. So you can see that there is significant resolution, and yeah, it's here also. You can see that there's significant resolution of the disease in the lung. So of course, he was clinically responding to treatment, but this provided additional evidence of clinical improvement. So I'll just quickly run through another case. So this was a 33-year-old female who we had seen in 2019. She essentially presented with fever, arthralgia, and some kind of weight loss. Nothing specific on the labs, and she was treated with numerous antibiotics and really nothing significant even on exam. So if you see her white cell count and all of that, was initial blood cultures was sterile. Testing for HIV, etc., was negative. Anti-nuclear antibodies were negative. The serological test for typhoid was also negative. A tuberculin skin test was negative, whereas an IGRA was positive. But this is very, 40% of India has latent tuberculosis. So positive latent tuberculosis test does not tell us it's tuberculosis. So she had undergone a whole body PET-CT. Unfortunately, I couldn't get these images, but all I'll say that it was really not remarkable except for a hypermetabolic spleen and marrow. So this also helps us in a way, because in patients with pyrexia of unknown origin, this kind of finding where diseases or uptake has been limited to the spleen and marrow is useful, because then your lymph node pathologies to a certain extent are excluded. So this is a young female with pyrexia of fever of unknown origin with night sweats and weight loss, splenomegaly on CT, and splenic and bone marrow uptake on whole body PET-CT. So we would really think of 2 or 3 things. In terms of infections, you'd still consider enteric fever, that is typhoid and paratyphoid, brucellosis, tuberculosis, and infectious mononucleosis. The absence of lymph node uptake does not completely exclude lymphoma, because splenic lymphomas and bone marrow lymphomas have been described. And adult onset Still's disease is a diagnosis of exclusion. So this, and then, as we were planning for further evaluation, we got a call from the microbiology lab saying that a blood culture had flagged positive, had flagged and was showing gram-negative rods. And this is how the culture plate looked. So this was Brucella melitensis on blood agar, and the final diagnosis of brucellosis. So she had received rifampin and doxycycline and made a complete recovery. So this is again something that I'll just run through. So a lot of our consults in ID are for pyrexia of unknown origin, which is really fever for 3 weeks, but our threshold is kind of shorter. So any undiagnosed fever which is longer than a week to 10 days is pyrexia of unknown origin. So you do a bunch of tests before you kind of label it as pyrexia of unknown origin. Essentially, in terms of imaging, an X-ray, chest X-ray and an abdominal ultrasound are mandatory, 3 sets of blood cultures, and a bunch of other tests. So, and really how you think of pyrexia of unknown origin is in terms of infection, malignancy, and autoimmune diseases or rheumatological conditions and miscellaneous conditions. So a lot of it in various studies has been reported with mycobacterial infections, lymphoma, giant cell arteritis, so on. So there's a very long list of possible causes. And in terms of evaluation, we do find intra-abdominal abscesses and tumors. The incidence of this is decreased. Infective endocarditis, again, blood culture techniques have improved, echocardiographic techniques have improved. So infections, at least in the West, account for about 20 to 25% of cases. So tuberculosis is something which is the most common cause in India. So in fact, when I speak to hemato-oncologists, they tell me that almost 90% of their patients with lymphoma have been on empiric anti-tuberculous therapy. So that's just like a fact that we have to keep in mind. So yeah, so in terms of diagnosis, in India, again, FUO is far more often caused by an atypical presentation of a rather common disease than a very rare disease. So you would even sometimes think about, we've seen a lot of patients with tuberculous pericarditis, for example, have present as pyrexia of unknown origin, and these are diagnoses that we don't see very commonly in the West. So vertebral tuberculous osteomyelitis and so on. So the question really is, what advantage does whole body PET-CT give us in terms of diagnosis? So traditionally, the recommendation is an abdominal and a chest CT, but this has really been to some extent superseded by whole body PET-CT imaging. So, but the traditional teaching is that nuclear medicine imaging is reserved for cases in which the initial evaluation remains negative and screening look at the entire body is desired. And gallium-67 and indium-111 labeled leukocyte scanning, both of these we do not use, are highly sensitive by virtue of including the whole body. But if you look at our textbook of, this is Harrison's Principles of Internal Medicine, so they talk about the approach to a patient with pyrexia of unknown origin, and I had mentioned all these tests. So the idea is that if you do not have potentially diagnostic clues, you would have a low threshold for getting an FDG PETCT or a labeled leukocyte scintigraphy or gallium scan. And if it is abnormal, then you proceed for appropriate biopsy. If it is normal, again, you go through the history and so on. And then if you're not able to get a diagnosis, then you do a temporal artery biopsy and a chest and abdominal CT. So somewhat this has been reversed in terms of getting a FDG PET-CT first, and then if it's normal, doing a chest and abdominal CT. So I mean, there is, I would say, no definite consensus. So this is a patient who's presently under our care. He has advanced HIV with a CD4 count of less than 200, presented with fever, night sweats, and weight loss. So pyrexia of unknown origin, constitutional symptoms, and he had some cervical lymph nodes on exam. Now, rather than proceeding directly for a cervical lymph node biopsy, what we often do is whole body imaging to look at other sites of involvement also. So you can see there is splenic involvement, adrenal involvement, mediastinal adenopathy, inguinal lymphadenopathy. And so this patient actually had what we would say is fever of unknown origin with disseminated lymphadenopathy and adrenal involvement in advanced HIV. So whenever you have adrenal involvement, again, your differentials kind of get narrowed to a couple of things, that is tuberculosis, histoplasmosis, lymphoma. And so he had undergone a lymph node biopsy that was initially reported as just reactive. I think he had undergone a cervical lymph node biopsy. Finally, he one day, a few days back actually, he started having blurring of vision, and then the ophthalmologist detected CMV retinitis. Then we went back and had a look at the lymph node biopsy. We ran CMV immunohistochemistry on it, and that was positive. So possibly adrenalitis is also due to CMV, although we did not get an adrenal biopsy done. But it would be reasonable to say that he has disseminated CMV with retinitis, adrenalitis, and lymphadenitis. He is presently on intravenous ganciclovir and recovering. So this is a 38-year-old female with diabetes and rheumatoid arthritis. She's had 3 episodes of pyelonephritis since January 2022, and presented with the 4th episode. And here she had undergone nuclear medicine imaging to rule out vesicoureteric reflux. So that was positive, and this is just another image, which is positive on the left and normal on the right. So direct radionuclide cystography and micturating cystourethropography have been compared. And I think there is more or less consensus that DRCG is in fact superior, not only in detection of renal scarring in children, but also in detecting vesicoureteric reflux in patients with urinary tract infection. So direct radionuclide cystography was what is often encountered ordered by the urologists in terms of excluding a cause for recurrent excluding vesicoureteric reflux in patients with recurrent UTI. So that's something that we use. But again, these tests are not often ordered by us, so we don't have too much of experience with their use. So again, chronic pyelonephritis. This is a patient with renal scarring, as you can see. Again, this is renal scarring on the right. And this is a normal scan, and again, one can see some renal scarring. So DMSA, again, it's not something that we see. We see patients more acutely with some variants of chronic pyelonephritis, such as xanthogranulomatous pyelonephritis. But there are some patients who present little more insidiously with with renal dysfunction, loin pain, etc. And those patients, a DMSA scan is usually ordered. So another thing very, very importantly is osteomyelitis. And I hope to take another 15 minutes. So osteomyelitis is I'll just give you a few cases that we have done. So this was a patient with blunt chest trauma with pulmonary drainage from the chest wall and who had undergone technician MDP bone scan. So as one can see, there is basically sternal osteomyelitis with purulent. So it's basically purulent, it's osteomyelitis, sternal osteomyelitis that one can see. And this is again very often used. So diabetic foot infections are what we see quite commonly. This is a patient with right first and fourth toe involvement. And again, that is really depicted here. Prosthetic joint infections, again, very often seen. And this is just one case of an infected right knee prosthesis. So this is a patient who had another case where a patient presented with, basically she had diabetes and had presented with cellulitis involving the left foot. And you can see this kind of calcaneal involvement here. And just go ahead. And so this was a patient where the suspicion was for, one is osteomyelitis, and the other was Charcot foot. And this is an article that I'd encourage you to read, a review article on Charcot foot and diabetes and an update on imaging. So this was actually a bone scan of from the article itself, a 53-year-old woman with a history of diabetes, a swollen right knee with no skin ulcer. The three-phase scan, that is early, blood pool, and delayed static phases with technician 19NM, demonstrated an increased uptake in all three phases. But this increased uptake may also be seen with osteomyelitis. So it's something that has to be clinically correlated, and that was exactly what was described in this in how it was read. So left cuboid bone infected pathology, associated Charcot arthropathy cannot be entirely excluded in view of the history of diabetes. So this is another patient post-cabbage with pain and swelling and discharge from the surgical site and sternal osteomyelitis. These patients require extensive surgical debridement, prolonged courses of a prolonged duration of antibiotics for about 6 to 8 weeks. So this is again what is depicted here. Then I think I will run through a case which is quite interesting. Was presented at a rheumatological meeting actually. Young man with fever and bone pains, 34-year-old man with fever, weight loss, and arthralgia for 2 months. So fever, weight loss, and arthralgia for 2 months. Multiple physicians had given him like a lot of painkillers and antipyretics, but there's no improvement. Really, this patient had normal white complete blood picture. Testing for HIV was negative. Cultures were negative. A tuberculin skin test and IGRA was positive. But a lot of the other rheumatological workup, rheumatoid factor, anti-CCP antibodies, HLA-B27, anti-nuclear antibodies were all negative. He had also undergone workup for multiple myeloma. And the reason for that was this technician bone scan, which demonstrated, you can see the uptake. So he was told that he may have myeloma and he was really worried, but testing for myeloma was negative. So multiple lytic lesions are seen here, and right. So he had undergone a whole body PET-CT with, and this is where the diagnosis was in a sense made, because there were reticular nodular opacities in the left lower lobe, multiple enlarged lymph nodes, lower paratracheal and subcarinal regions with a large subcarinal node. And of course, multiple lytic lesions, which were demonstrated on the bone scan, were also seen. And all of them showed increased uptake. So this is what one can see. So in such a case, of course, there is a wide list of differential diagnosis. But I mean, if when we see such large lymph nodes, our diagnosis tends towards tuberculosis. The other possibilities are disseminated histoblastomycosis, brucella. Um, the others would come kind of a little lower down. So bone marrow biopsy was done, which showed, again, histopathological evidence of tuberculosis with epithelioid granulomas and epithelioid histiocytes, lymphocytes, few plasma cells. However, the AFB culture and staining were negative. But again, these are all possibacillary sites where the burden of organisms isn't very high, and diagnostic yield from a single core bone marrow biopsy isn't, I mean, you can get a lot of, it's not a large sample, right? So that was negative. These are just the images of the TB involving the bone marrow, and you can see these granulomas here. So this patient was again put on RIPE therapy. He experienced a quick effervescence after several weeks of fever, and really was doing well. Reduction in intensity of joint pains within a week. Repeat bone scan after 6 weeks showed partial resolution of the lytic lesions. Joint pains had subsided, had come down. ESR CRP normalized. Completed 18 months of anti-tuberculosis therapy, and a repeat bone scan after 18 months showed no lytic lesions, and therapy was stopped. So really won't discuss much about skeletal TB for want of time. So final diagnosis was multifocal osteomyelitis due to tuberculosis. So reason I'm mentioning this, I put in this case first, is because if you look at a scan like this, without a clinical context, it is very difficult to interpret. And in like this gentleman was initially told, because of his age, young age, he may have so many lytic lesions, the thought was for multiple myeloma. But when we did a whole body PET, we had found evidence of lymph involvement. So clinical context is very important. This was actually a patient with carcinoma prostate for skeletal survey with multiple skeletal mets. So it's just very important to understand the clinical context. So now, just before I finish, I will just say that for we are don't deal with patients with osteomyelitis directly. We're more or less consulted by other physicians or surgeons for the same. So it's not often that a bone scan is or nuclear medicine imaging is ordered for osteomyelitis. So really, for non-vertebral osteomyelitis, MRI still has greater sensitivity. So what with us, what often happens is the nuclear medicine imaging has already been ordered, and then we are asked to consult for diagnosis and treatment and monitoring and so on. So, but 18 FDG PET and 3-phase bone scan plus single photon emission computerized tomography are what we have available in our center. So when this is commonly used is where metal hardware precludes MRI or CT assessment, or if MRI is contraindicated, then guidelines generally dictate that nuclear medicine imaging is the way to go. So for vertebral osteomyelitis, PET scan using 18 FDG combined, PET-CT is highly sensitive and really a negative predictive value of close to 100%. So specificity is good, but it may be compromised by the presence of tumors, degenerative spinal disease, or spinal implants. That really is one of the drawbacks of nuclear medicine imaging when it comes to osteomyelitis. So in one prospective study, including 32 patients with suspected vertebral osteomyelitis, who underwent both MRI and 18 FDG PET, MRI was more useful for the diagnosis of abscesses, epidural or spinal, whereas whole body PET was more useful for the detection of metastatic infection. So it's understandable. Your soft tissue delineation and imaging is better with MRI, and therefore an epidural or spinal abscesses is where MRI is kind of scores over 18 FDG PET. But metastatic infection, again, FDG PET would be the answer. So three-phase bone scintigraphy using label technetium, relatively sensitive and specific. It may produce false positive results in patients with non-infectious disorders such as fracture. Can also false negative results may also occur early in infection or in cases where in which bone infarction accompanies bone infection. Gallium imaging is again sensitive and specific radionuclide scanning for vertebral osteomyelitis. I do not think this is available at our center. Uh, Typical positive test reveals intense uptake in two adjacent vertebrae with loss of the intervening disc space. Labeled leukocyte scans, again, something we don't do. Rarely useful for the diagnosis of vertebral osteomyelitis because abnormalities typically manifest as non-specific photopenic defect with a reduced uptake of isotope. So it has high sensitivity for detecting evidence of inflammation. But again, you will see false positives and false negatives. False positives in cases of recent trauma or recent surgery, degenerative joint disease, bone tumors, Paget's. False negative if there's bone ischemia or if it's relatively early. And it's also time consuming and costly. So these are really the perhaps the drawbacks of looking of nuclear medicine imaging, but it has high sensitivity. So this is as infectious disease physicians, osteomyelitis is again some nuclear medicine imaging in osteomyelitis is not something we commonly order, but we do, if it has been ordered, of course, we do interpret it in and give a lot of weight to it. And it's perhaps also very useful in monitoring the clinical response to treatment. So the last is thyroid scintigraphy, and really, of course, we're not involved with the directly with thyroid scintigraphy, but one thing that we have been consulted on is because we're the capital of tuberculosis is tuberculosis of the thyroid gland. So these are patients who've been referred who had a thyroid biopsy and have been found to have granulomatous thyroiditis. So the question is it something like PQ Irwin's thyroiditis or is it tuberculosis? And generally, as far as I could gather, in PQ Irwin's thyroiditis or subacute thyroiditis, the uptake is low, whereas in tuberculosis it would be high. But it is something that we very rarely see. And it is a diagnosis that I think we would have seen maybe 2 cases in the last 10 years. So it's very rare, tuberculosis of the thyroid gland. But again, because we see so much of TB, we have seen about at least 2 cases in the last in the last decade. So it may resemble toxic goiter or acute thyroiditis, or may follow a subacute or chronic pattern. Necrotizing epithelioid cell granulomas, Langhans type of giant cells, and demonstration of acid-fast bacilli by Ziel-Nielsen staining confirms the diagnosis. But again, this is frequently negative. So there is quite a bit of literature on thyroid tuberculosis, but the thyroid scintigraphy may provide some kind of a diagnostic clue in terms of it. If it is tuberculosis, it's an active infection, there will be uptake. But if it's DQ events thyroiditis, again, the thyroid uptake is low. So that brings me to the end of my talk. So I'll be happy to take any questions.
Thank you very much, Dr. Ramesh. Excellent talk and very comprehensive review of the role of nuclear medicine in infectious diseases. And thank you for sharing all those clinical cases with us. Very, very helpful. So I'll go ahead with the first question. So you showed us that algorithm in the Harrison's internal medicine textbook.
Right.
Clinical,
go back to you want to open my presentation?
No, that's fine. My question is, what is your threshold for getting FDG PET-CT in pyrexia of unknown region? Is it in your first workup, like with the CBC and all other imaging, you also order an FDG PET for these patients? or it's far further down in the line?
So, I mean, we do a complete physical exam and we look for, cervical, axillary, inguinal nodes. But a lot of patients present with nodal pathologies which cannot be detected on an X-ray or abdominal imaging, especially if they have mediastinal involvement or small abdominal nodes. So if an X-ray, chest X-ray and an abdominal ultrasound are normal, and we are thinking of in terms of lymph node pathologies, our threshold for getting a whole body PET-CT is quite low. So we often we go for it quite early in the evaluation, because I mean, to some extent, it's also the setup in which we practice, where we try and once a patient is admitted into hospital, we try and reach a diagnosis within 48 to 72 hours. So rather than delaying it. So if some cases, if a CT chest and abdomen has already been ordered, then obviously we wouldn't really look at PET unless we think of the disease having evolved. So I remember a patient, I've not discussed this case. So a patient post-renal transplant who had Pyrexia of unknown origin, CAT scan of the chest and abdomen were normal, and really we're not sure what is happening. And I think we had got a whole body PET-CT done, and that did show kind of a scrotal uptake. And I think he was diagnosed with ultimately a lymphoma, but it was a very, very rare case. So our threshold is actually quite low, and our preference is always, if you have a choice, it's always whole body PET-CT, because we can also look at activity in terms of if you have multiple lymph node sites involved, we can then decide which lymph node to biopsy. So sometimes, the getting a mediastinal lymph node biopsy is difficult. So if you have evidence of abdominal nodes and they're showing a lot of uptake, something that is more easily accessible via percutaneous CT guided biopsy, that is something we look at. Yeah, so that's it's just something that we do have quite a low threshold for in terms of ordering it.
Yeah, thank you. This makes perfect sense. Anybody in the audience who would like to ask questions?
Yeah, thanks, Sam. I had a comment on that FDG PET workup for fever of unknown origin as well. So in your beginning slide,
Right.
you said that cost may be a confirm, and you cited some cost of $150 to $350 for FDG PET in India, which,
right,
if you look at the US standard, it's pretty low and cheap actually, but that's a different story. But I would like to know what is the cost differential between a whole body FDG PET-CT and, say, for example, a chest CT scan and combined with an abdomen pelvis CT scan?
Right. So, I mean, it varies from center to center, but it would be perhaps about the average, let's say, CAT scan of the chest and abdomen would be about maybe around 6,000 rupees, somewhere around $80 or $90. Whereas it's $150 or around 12,000 rupees for the least expensive PET-CT in the city. So, and so it's that is one. And the other thing, actually, one of the other factors is a number of other hospitals do not have this facility, like our other branches of Apollo. So when they require a PET-CT, the patient has to be shifted in an ambulance to our hospital and undergo the scan and then get shifted back. So that's also factored in. But if you do see a patient in our outpatient clinic, or if the patient is already admitted in our medical center, then we do tend to prefer CT, whole body PET-CT. Yeah.
Yeah, because in the US, so frequently, cost is cited as an example that FDG PET is an expensive test. but the average reimbursement for a whole body FDG PET CT in the US, if you go by something we call CMS or Medicare, that's
Right.
around $1,600, and in the range maybe from $1,400 to $3,000 or so.
Okay.
And if you look at a chest CT scan reimbursement for with a contrast enhanced study, it ranges from $650 to $1,250, $1,250. And for
Right.
abdominal, it goes from $900 to $2,000. So if you
Right.
take an average of about 900 for a chest CT and 1,200 for abdominal pelvis CT scan, it becomes $2,100, which
Right.
is actually a little bit more than the average reimbursement for an FDG PET CT scan. And on
Right.
top of that, you get you have to do two studies.
Right.
People may have contrast allergies, and you have more radiation exposure. So the touted advantages that or disadvantages of FDG is that it's expensive is actually not that true. I think it's more of an issue of availability, as you pointed out. And at
Right.
least in the US, for a long time, we did not have CMS reimbursement for use of FDG PET in infection and inflammation imaging, especially fever of unknown origin.
Right.
Only last year, they basically removed that non-coverage determination. So now more and more people will start using it.
Right.
I think the disadvantage is lack of the anatomic resolution and specificity
Right.
that you pointed out, rather than the cost, and we need to
Yeah.
work on that. So that I think needs to be conveyed a little bit better to the. I think a lot of our referring physicians have that same thing. Or FDG is very expensive. It takes a long time, and,
Right.
and those kinds of things in their mind that prevent them from ordering an FDG rather than. But I think your approach makes sense. If
Right.
you are looking for a screening examination, doing a whole body screen first would
Right.
be useful, and then do a focused evaluation of the area of interest.
Yeah.
That would actually fit well with the guidelines of ALARA as well, and image gently and image wisely principles as well.
Yeah.
So,
Absolutely.
I do have a few more questions, unless somebody in the audience have some questions.
I don't see anything in the chat box. Dr. Thakurkar, go ahead.
Okay. So in the you showed some interesting cases. So in the US, the differential for ring enhancing lesions
Right.
on brain MR actually would include CNS lymphoma.
Right.
And the second common one is basically cryptococcal
Right.
infection. And we in centers or in regions where HIV is prevalent, actually it's more common, and we do use FDG PET for that. And one of the things is if it lights up, because CNS lymphomas are intensely FDG. Usually FDG is not that good for brain metastatic evaluations,
Right.
but CNS lymphoma tends to be sort of an exception, and we have pretty intense uptake in CNS
Right.
lymphomas. And so if the lesions light up, we actually empirically treat the patients for lymphoma rather than sarcoid, cryptococcal infection. So that's a little bit different, because although the incidence of TB in the US is slightly rising, it's still not as prevalent as in India. And the second thing is we have more endemic sarcoidosis, which
Right.
kind of
Right.
acts like TB. It's like,
Yeah.
so in India, we used to call TB as the great mimicker. Here we call
Right.
sarcoid as the great mimicker, because
Right.
it can mimic everything.
Yeah.
But for that second case, I was a little curious. Do you guys do cryptococcal serology there, like the antigen testing?
Yeah. Yeah.
And
So this.
that was negative for
Yeah.
that patient?
Yeah, it was very surprising. And one thing I'll mention is that the sensitivity of cryptococcal antigen in the blood and CSF is much higher in patients with HIV than in non-HIV.
Okay.
So this patient was non-HIV as in post liver transplant. So the absence is, of course, it's the absence of the CRAG, that is cryptococcal antigen, being positive. Is to some extent explained because he's non-HIV, but again, it was quite surprising that the PCR2 was negative. I mean, sometimes you just need repeated exams, I'm guessing, repeated lumbar punctures at intervals. And if in ID there is a saying, right, tissue is the issue. So sometimes if you're not able to, you can do every test in the book, but if there is a tissue that even if it is difficult, like a meningeal biopsy or something, it may be worth pursuing.
Okay.
So yeah, so this patient actually had, we detected cryptococcus only on the third lumbar puncture, and he was just not improving. So before we did a meningeal biopsy, our plan was do a lumbar puncture, run the tests again. If we completely exclude, if you're not able to find anything, and then proceed. But luckily, we found cryptococcus. So
yeah. Another thing I wanted to touch base on was the DMSA and VCUG scans that you mentioned. They're rare in the US as well, actually,
right.
mostly seen in the pediatric setting, and a lot of people don't practice pediatric nuclear medicine here. But what I was curious was, what's the perception of exposure of radiation from various procedures, like say nuclear medicine? So we have radionuclide VCUG studies and fluoroscopic VCUG studies. And generally fluoroscopic VCUG studies are more preferred because they give a little better anatomic details.
Right.
But radionuclide VCUG studies can actually be more sensitive for smaller amounts of reflux, and they actually provide in general less radiation exposure to the patient compared to the fluoroscopic VCUGs. Now, bear in mind, the techniques of fluoroscopic VCUGs are also changing, and they're trying to decrease the radiation exposure. But still, by and large, there's less radiation exposure from radionuclide VCUGs compared to fluoroscopic. So does that become a consideration for you guys in ID when you order a test, or you just say we want the best test available, kind of a thing?
Yeah, to be honest, like we don't use this. We don't use the predominant test. About 99% of our tests is in terms of it being ordered by us is whole body PET-CT. So I'm not too sure of how the urologist or nephrologist would use it, or but I'll say one thing, that we have we've had COVID for about 2 years now, and the number of CAT scans of the chest that have been done, unnecessary CAT scans, are just incredible. Like it's so I'm in a way I would say that a lot of, and it's even it's surprising, patients would I've also heard a couple of patients who walked into a diagnostic center and say that, look, I have COVID, I want a CAT scan of my chest, and they'll come with a report saying that, look, I have 7 on 25 or 8 on 25, a score, CT severity score. So generally the perception, at least among the physician population and even the lay population, is not to be too concerned on radiation, but that's just my very limited experience. So.
Okay. Yeah, because we run across this all the time, especially in tests that are done serially for follow-up evaluations. Some people raise concerns about radiation, but I think a lot of it is, the general population usually is not that keen on those topics. Especially if you're a patient, you want the best test, basically.
Right.
But in the media, I think it becomes a good.
And it's also to some extent like it. It kind of boosts the morale of the patient when they can see visually that their disease has come down.
Yeah.
And it also kind of emphasizes the importance of continuation of treatment to complete the course, so that we can counsel them in terms of telling them that the disease burden is reduced, which is evident on the scan, and what our goal of treatment is, and if some amount of treatment is remaining.
And sometimes it's actually gender specific as well. Like in this case, I don't know how much patients you see for but posterior urethral walls are more common in male compared to female, and so in males, you maybe would prefer fluoroscopic VCUG, but in females, since it's uncommon, radionuclide VCUG actually may make more sense because
Right.
anatomic deformities are less common. So you would go with a test that gives less radiation exposure and less radiation to the ovaries, which has implications for fertility down the road for that patient. And there's some data on that actually. So, but anyway, lastly, I would like to end with your osteomyelitis thing. You presented some good cases, and you compared the advantages of MR and drawbacks of and advantages of PET. Do you guys have access to PET MR? Because I think this would be a good indication for evaluation with PET MR, like spinal abscess or osteomyelitis or diabetic foot. Most of the PET MR right now is focused on liver and pelvic oncology and neuro indications. But I think infection imaging, especially in diabetic foot or spinal osteomyelitis, maybe some other indications for PET MR evaluation, especially in challenging cases, actually.
Right. No, we do not have it at our medical center.
Okay.
So.
Good. There's a question in the chat. Saima, could you post a look at it?
Yes, so there's a question on the chat by Dr. Ravi Kiran Parigala. I'm sorry, I hope I'm pronouncing it right. Thoughts on using PET for evidence of clearance of infections like tuberculosis or osteomyelitis?
Yeah, so actually, Dr. Ravi Kiran Parigala is one of, he's also an infectious disease attending who practices at our medical center. So he was my mentor during fellowship. So I trained under Dr. Ravi Kiran. So anyway, yeah, I think it's a really valid question. So obviously, I would say a clinical assessment is a must in terms of looking. So I've rarely found that there is a discrepancy. I've invariably, if patients are improving clinically, you will find evidence of decreased disease activity, whether you're using conventional radiography or nuclear medicine imaging. But to some extent, it would, with PET, what you can also kind of demonstrate is clear resolution of disease activity in terms of more of a quantitative effect. So because at least with lymph nodal TB and even pulmonary parenchymal TB is a disease that heals by scarring. So you may often have radiological persistence of abnormality, but not necessarily disease activity. So like we have a lot of patients with lymph nodal, especially young females with cervical lymph node TB, where the lymph nodes do not completely regress in size, but they're definitely they're not symptomatic with the disease. And the same thing happens with lymph node involvement at other sites. So the size may not completely go back to normal, but generally the patient feels better and disease activity is reduced. So where we have done follow-up PET CTs, we find that it has it's made quite a difference. So and it's sort of easier to quantify also, I feel, in terms of the resolution in the uptake. So the decrease in the uptake, I think that makes a big difference.
Yeah, I think I would like to add something here. There's some data from South Africa that showed that you can actually use PET to assess responders versus non-responders in TB, and then there are some good papers on that. What interests me is two things: A, the responder versus non-responder, which can be addressed with an interim PET scan. But the duration of treatment, because these treatments are long, 6 months, 8 months, and in resistant patients, even longer kind of a thing. And these were basically on empiric data of how long it takes to clear the infection using blood work and clinical symptoms. And I was curious, since unfortunately TB is, well, not unfortunately, fortunately TB is not that common in the US. So we don't have that much patients, but it would be a good study to determine whether we can use imaging along similar lines that we use for cancer to determine duration of treatment for these. We have to be cautious though, because a negative PET scan does not necessarily mean no disease. It just means no detectable disease. And
Absolutely.
we have limitations on resolution of how much cancer tissue we can detect. So it's usually up to a tune of up to about 1 gram, which could be up to 100 million to 1 billion cells that we can miss. So traditional thought is like, once the PET becomes negative, you still want to give 2 more chemotherapy cycles to take care of that potential residual disease. And if it remains good, then the patient goes on to complete cure or response. And if you could try something like that in TB patients to see, resolution of disease, and say if a patient cannot tolerate more therapy, if you stop it, does it come back? And in patients who can tolerate, how much more? So do you really need the 6-month therapy or 8 months therapy kind of a thing? Or can we, especially in fast responders where the response is very fast, would they reach cure level faster in say 4 months or 3 months instead of 6 months? Those would be good studies that actually you could prospectively do in India pretty easily, given the number of patients who have TB there.
Right. Absolutely. Yeah. So, I mean, there is a trend towards shorter treatment regimes, but given the risk of relapse, it's always something that physicians worry about if you're worrying about stopping treatment too early, especially if there's disseminated disease, and that's what we commonly see in our HIV population, a lot of disseminated disease involvement. So where I mean, if you look at the guidelines, they would say that unless a patient has CNS tuberculosis or bone tuberculosis, 6 months of therapy should suffice, even if it is disseminated. But those are guidelines which we take with a pinch of salt, because a lot of our patients are heavily immunosuppressed, and we see a lot of patients with advanced HIV with CD4 counts of less than 100. So that's something to keep in mind. So.
Right, I think excellent talk, Dr. Ramesh. I would like to thank you once more, and a very nice discussion. Thank you, everyone.
Thank you very much for the
we'll
opportunity.
meet again next month on the first Saturday, and we'll be sending you the Zoom invite. Thank you, Jyotsna, and everybody else in the audience.
Thank
Bye.
you.